Hey, thank you for joining us. We have a treat today. Got two speakers. We're doing a double act. We have Lynn Laidlaw with us. Uh, Lynn is a highly experienced patient and public partner to research and peer researcher, and she conducts research on patient experiences living with long-term multiple conditions, shielding experiences, and co-production methodology. And Lynn lives with a rare disease and multiple long-term conditions. Our other speaker today is Dr. Beatriz Gulau. I hope I pronounced that correctly. So Beatriz is a senior research fellow at the University of Glasgow and MRC new investigator. And her research program, her focus is improving the relevance and communication of statistics and health data to support health decision making. And she's been funded by MRC and IHR and the Wellcome Trust. So Beatriz conducts her research in parallel to her role as a senior statistician and methodologist, supporting the design and delivery of clinical trials, including in oral health and urology. So I guess at that point, thank you both for speaking to us today. We're really happy to have you here, and I'll hand over to you.
Just one quick comment to everyone. The session will be recorded. So if anyone has any problem with that, just let us know in the chat, and then there will be a Q&A session by the end. Sorry, Jude. Thank you.
Right, so hi everyone, and thank you for turning up and listening to Bea and I talk about It Depends, so how public partners can shape statistical and data research. And I'm going to let Bea say something about why we came up with this particular topic. But first, as we've called our presentation, It Depends, to highlight what we feel is the real importance of context, we felt it was only fair to share our individual contexts and positionalities with you all. So, as you've heard, I live with a rare disease and multiple long-term conditions, and I'm involved in multiple projects with multiple organisations, researchers and institutions across the UK and further afield. And I'm increasingly health and research literate, including conducting research, but my positionality is always someone who lives with conditions. And that means I need to navigate treatment and health services. And for me, it's about combining my different types of experience, my lived experience, but what I know and understand about research to make health research the best it can be. Because no one cares about research more than people living with conditions. And if I didn't think my involvement could help, I wouldn't waste your time, as it's too important. Bea.
Thank you, Lynn. So I am a statistician. That's my background, and that's how I come to these issues. But I've been trained as a healthcare professional. So my first career was as a dietitian, and I always find that my passion about data and statistics, but also my understanding of communication and patients' views comes from that mixed career background. So I truly believe that statistics are subjective, that a lot of the decisions we make in our analysis, in our design of studies are debatable. And that's the perspective that I come from, is that I think there's a lot up for debate, and I think patients should have a voice in that debate. So we come from that perspective. And I must say that when we came to, we're going to focus on 4 key aspects. So I wrote down drivers of meaningful involvement, but that I think are particularly challenging in the world of statistics and data science. So we're going to talk about purpose, identity, relationships, and reflexivity. And I would like to finalize kind of my context, saying that as a statistician, there are a lot of things that Lynn brings to my attention that I never thought about before. So such as making a statement about my context before I start a presentation. And I think that is a prime example of how opening yourself up to new ideas makes the whole thing richer. Your whole experience as a researcher and as a statistician richer. So I wanted to give that as a, because Lynn, I must confess, I've never done a positionality statement. And I wanted, because there might be other statisticians here on the call that might identify with that. So I wanted to say that I think it's important, and I think it shows how much I learned from you. Do you want to say something about the 4 topics before we move forward?
No, so I think it just reflects our relationship as well, in that we came together to discuss what we were going to talk about, and it was very iterative, wasn't it? And we batted ideas back and forward together, and then we decided on these 4 topics. Yeah.
Yeah. Okay. So the first one, let me just see. We've tested this before. Yeah. Purpose. I guess, I think, should I start, Lynn, and then?
Yeah.
So basically, we came to purpose. It seems so obvious, and yet quite often it isn't. Because when we're talking about patient and public involvement in data and statistical research, there is sometimes a question mark about why do I want patients or members of the public to be involved in this kind of research, and making that clear first to yourself as a statistician, but also obviously to the public partners you are wanting to work with, is essential to move things forward. So I think we've all been in scenarios where it's not clear for any party what is it that we're trying to achieve in that scenario. I think in statistical research that becomes particularly important, as it is more technical, and therefore I think it needs more reflection on what the ultimate aim of the activities are. So do you want to?
Yeah, so I don't think we think enough about purpose in general when it comes to involving people. And actually, I've popped a really nice paper in the chat called "Who Should I Involve in My Research and Why" by Christina Staley, and patient partners such as Derek Stewart co-wrote that. And I think you really need to ask yourself about the purpose. So, are you doing it on the grant application form? How do you really feel about involving public partners in data and stats research? Are you doing it because you're expected to do it? And also what thinking about what skills and attributes do people need? Researchers and public partners. And I think part of this is being really open about the purpose at the start, so everyone understands it. Because how can you tell whether you've achieved what you want to achieve if you're not clear what your purpose is? But also being really upfront about non-negotiables, so then people can make an informed choice about whether they want to get involved in what you're doing.
Yeah. So we actually discussed a particular example that we've worked together on, and I'll get to that in a second. I wanted to talk about the fact that this idea of what the purpose is. I said earlier, I come from the perspective of, statistics are inherently subjective. There is a big debate in the statistical world, and statisticians that have joined the call will recognize it in terms of Bayesian and frequency statistics, and whether one's more objective than the other. I really don't believe any, because every data that we and as we're analyzing it, it's made of decisions, and someone needs to take those decisions, and those decisions might lead to different answers. And I don't know if you are familiar with this paper, which is, it makes you laugh that a bunch of data experts were given same data, same hypothesis, went away to analyze it, got to completely different conclusions. And I'm sure that anyone who has practiced statistics will recognize this. And so it is being open to the idea that if there are a lot of decisions that are up for discussion, why are we only involving clinicians, for example, in those discussions and not patients? So that's when you start forming the purpose, which is, should we be opening up these discussions to more people when we have the opportunity to do so? And I think Lynn is going to say a bit more about that.
Yes, I think it's fair to say I'm a call girl more than a stats girl, although I'm involved with B, and it's that collaborative thematic analysis that brings the richness, I think. And I just wanted to raise something. So I think as you can see, my snipping abilities are very good with regards to PowerPoints, but this is, again, a really, really nice paper. And I think I've popped in the chat as well. Contributors representative as long as they agree. And I think there's an essential paradox here of, like, sometimes public partners being seen as too naive to be useful, especially in things like, technical subjects like statistics, or so professionalised that it somehow negates our lived experience. So, and I like to call this, it's like the Goldilocks porridge rule of involvement. That public partners have to be just right without any say over what just right might be. And, I'd like to question this, because why are public partners the only people not allowed to be knowledgeable in research? Where we value expertise. And unfortunately, becoming really research literate hasn't cured me of any of the multiple diseases that I live with. So I know that there's a lot of debate about, because we're talking about purpose and who you involve, and and I suppose what B and I have talked about is, well, it depends, and it depends the project, what the purpose of your project is, who you want to involve. But I think just being aware of this contested debate around naivety and professionalism is, I think, really useful.
Yeah. So has Lynn and I got involved? So Lynn and I have worked together in multiple different projects, and I must say that is something that we've discussed over and over again. The fact that relationship and the fact that we are building a common language, and this communication is essential in order for things to work out. And so I'll give you an example of a particular project that we've worked together on, and Lynn was involved since the very start. So before it got funded, we've had conversations about this project. So this project, which is the case study that we're going to focus on, is called Pinpoint, and it's about patient and public involvement in target differences. Target differences are differences between two treatments in a particular outcome that we use to design clinical trials. And they're often based on clinically important differences, but patients do not get involved directly in defining what that actually is. And that's where the project came to sort of fill that gap. So the overall aim is to identify, adapt, and test methods and tools to ensure patient-important differences, as we've called them, are considered at the trial design stage. We also have work further down the lines. We haven't started working on that to involve patients in the discussions around sample size, because as any trialist in the call will know, even when you have identified an important difference, and hopefully that will be done through conversations with patients in the case of Pinpoint, then when we move on to the sample size, that might not be the final difference that gets used in your clinical trial. And so it's opening up that discussion, and it's all about transparency of the process. So this is the Pinpoint project. Basically, I wanted to say something, because obviously we'll have a mixed audience today, about the fact that this is in the context of clinical trials. Clinical trials, for those that are not familiar with them, are basically you have a population of interest, you will recruit to a specific clinical trial, and in its simplest form, you toss a coin, and that decides whether people go into treatment 1 or treatment 2. And you are trying to find out which one's better for patients. And there are multiple things that we use to determine whether a treatment's better than the other. One of them is the outcome. And so famously, core outcome sets are a way to try to address lack of consistency in research and clinical trials. And there is patient and public involvement in core outcome sets. Outcome measures, I think it's a bit more mixed, which is, once you know the what, how do you actually measure it? And I know Lynn may say something about that. And then finally, you have the clinically important difference. And this is where we're talking about that difference. So the example here was fatigue has the outcome, a fatigue score on a scale of 0 to 10 has the outcome measure, and then your difference in scores is going to be your difference, your clinically important difference is what you're trying to determine. Yes, as I said before, even though this is clearly something that's up for debate, that needs external input, we have found consistently that patients and the public do not get involved directly in determining a clinically important difference. And that's why we called it a patient-important difference. It was related to the terminology and how it can be exclusive. And again, I know Lynn is going to pick up on that, the fact that terminology can exclude people from conversation. So as an example, just to give you an idea of what we're talking about, we wanted to develop these tools that ask patients about, what is an important difference to you? And we sort of had this idea that maybe this would involve some contextual information because people need to know about the treatments, potentially the side effects of the treatments, and then we would have specific questions about important differences. So I would consider taking a treatment over another if it reduced my risk of a new surgery by X. So this is the sort of example. We're not at a stage where we have a tool to be released. So this is just a fictional example that we thought would be helpful to bring to life what the project was about. And again, speaking to Lynn and to the other public partners that were involved in the design, that made a massive difference in ensuring that I could bring to life this sort of methodology so it could speak to different people and it could eventually get funded. So I'm going to go back to purpose now. And the idea that purpose in terms of PPI in statistical projects doesn't need to be a single thing. And so Lynn and I discussed this and how I always see Lynn, Derek, and Irene, who are in this slide, has involved in the strategic part of the project. So they come to the external advisory group meetings. We have separate meetings where I'm telling them, these are the question marks I'm having about how to design and conduct a study. These are the early results, and they pitch in terms of how should I be, doing a better design so it speaks to more people, or so it's, more effective in its implementation. How should I interpret these results? So all of these conversations are what I bring to conversations with Lynn, Derek, and Irene. And I must say that their experience in patient and public involvement makes a massive difference there. Because, and I told this to Lynn, I often think that it wouldn't be fair for me to be asking those questions to people that are completely naive to the research process. It would be really difficult to have meaningful conversations about these bigger questions with them. We then have a separate group. So basically, Lynn, Derek, and Irene help me inform how am I conducting the meetings with a separate group. And that separate group helps me with more applied decisions of the project. So that tool that I've just showed you, we bring to them and we decide, what sort of information would look good here. How do I think people will understand that? They'll help me test the different tools. So they basically have very different backgrounds, different experiences. And it's because PPI in a project doesn't need to have a single purpose. It can have multiple purposes. And that probably means different people are more appropriate to do it. The final I wanted to say about this is that I've also heard a criticism of working together over and over again with the same public partners, which I don't think it's fair again, because I work over and over again with the same clinicians. And it's because we work well together and because we build this common language, as we were saying earlier. And so, yes, I think it is much richer, much better. And we do better research because of it. And I wanted to make that final point about purpose and about public partners as experienced members of the team being a plus. Lynn, over to you.
Thanks, Bea. So I wanted to talk about this whole, what I feel is this tension when we're coming to statistical analysis and in clinical trials and whatever about meaningful versus measurable. And because it's the issue that's produced the most conflict for me regarding the way that I work with researchers and whatever. And Bea will laugh because I'm going to use an example that I always use about a cardiology trial that I was eligible to participate in. So of course the bold Lynn emails the team and says, oh, well, what's your primary outcome for this trial? Because it wasn't in the participant information sheet. And I was told that the primary outcome, so this was a trial in chest pain, was if you took this medication, you'd be able to go on a treadmill for 30 seconds more without having chest pain. So I didn't participate in the trial because actually that wasn't an outcome that was meaningful to me. It was something that they could measure, and I question whether it's meaningful to anyone that lives with angina, or indeed what the clinical significance was. And when we talk about validated measures, so whose perspective are they validated? And I'm involved in some research looking at the pain catastrophization score, and what we're finding is actually it doesn't really measure what we think it is, because actually pain catastrophization isn't a thing. And I think it's really important when it comes to research waste, because the medications and treatment fail because they're ineffective, or because the measurements that we have can't capture what matters to people living with the disease. And also, find some of the language that we use, cohorts, multimorbid patients, in whatever, really, are we reducing people to a data point? Are we forgetting that these are people, that they're not cohorts? And one thing that really gets my goat is, can we meaningfully measure health-related quality of life via a 5-point scale, like the EQ, like the EQ5D? And sometimes I think, I work with researchers. Do we spend all this time writing this wonderful grant application and put together this clinical trial, but do we take the same time and care selecting outcome measures and interpreting the results? Or would you just say, oh, health-related quality of life, I know, we'll just stick this in because that's what we use, without questioning, actually, what is this? What is this measuring here? And I know for some research that's been done by Sean Trewick and others, that the primary outcome of the clinical trial doesn't always match what's important to people living with conditions. And also, I think an aspect of clinical trial that's always kind of confused me a bit is that, as we said, we're all individuals, we've got different contexts and experiences. Why do we have a single primary outcome? And actually, should we be matching it to what's important to that individual participant? And I wonder, are we bringing public partners into the research world, into our statistical data world, instead of them in their world? And Habermas talks about system world and the life world, and there's a massive gap between it. And actually, what would it look like if we co-developed some statistical methods and started from scratch? Would it lead to better research, more meaningful research? I don't know. I would like to think it would. And I put the slide up because I really love this paper. And again, it's in the chat. And, in the first one, we put patients at the centre. And we hear this all the time, don't we? But what autonomy do any of us have when we're put somewhere by others? And this is, that we sometimes think of PPIEs as box ticking. But how this group saw it, that developed these illustrations, where that patients in the public were the axis. They were the centre of it all, not put there because that was the way that we did it. And we need to ask, who starts the cycle? Actually, who gets to ask the questions that leads to the research? And I just love this slide, because I wonder, do we have research as imagined versus the research that people participate in that's actually experienced?
Do you want to start this one, Lynn, about identity?
Yeah, so I think there's so I put again a great blog by Annette Boaz for the London School of Economics in the chat, and she talks about enabling the creation of academic identities that like different academic identities that allow for authentic collaboration. And I wonder, you know, how much of an identity depends on the perception of others. And I I get it. You know, my eldest son finished his PhD last year, and I know how hard he worked. But acknowledging my skills and experience doesn't detract from B's. They're they're complementary, and I think it's really challenging for researchers. You know, because your research is your baby, and sometimes we come along and tell you your baby's ugly, and that's really difficult. That's really difficult to hear. So I think we need to think about our identities and actually, you know, how much of it a part of it is, and actually are our individual identities threatened or questioned by involving patients in the public in statistical and data research, because I know when I did research myself, when I actually conducted research, and I'm not a trained researcher, it really led me to an identity crisis. What was I? Was I public, you know, was I a lived experience person or a learned experience person? And we silo people. And I know that there'll be people in the audience that have, how do you combine your different identities? Because we're all intersectional beings.
Yeah, so I think this is such an interesting point about identity and how academics' identity might be questioned through these conversations, or that academics might feel the need to say, I know best and this is how things are going to get done. And I think as statisticians, there's potentially a challenge that comes from the fact that we're not trained to be speaking to patients. So what is the role of the statistician in this process? And I think part of what happens is that a lot of statisticians don't really know how to open up the discussions and how to evolve in terms of their identity, to have conversations with patients and also bring it back to their, for example, statistical analysis plans. So I do think this is important. It does speak to the idea of communities of practice, and I don't know if you're familiar, but Laura Gray has leads one that is on LinkedIn, and so I think in a way it's statisticians coming together also to talk about the challenge they might find and how to overcome them. But there's no question that we all have something to gain if we listen to each other. It doesn't mean that we will always agree, obviously, right, Lynn? Like, it's not like we've always we have conversations and we're open about disagreements, and that's how we evolve. But it might be that one time we're making a decision that everyone agrees with, and another time we're not, and that's part of the process. But I think it is the faith in the fact that the conversation moves things forward that keeps us working together. It's not about anyone winning the conversation. And I think that's really important for people to be aware of. So I'm going to move us forward to relationships, which I actually think I was already starting to touch on, has something that I think holds it together. And it is this communication between people that is cool, but takes time and takes something that, again, Lynn, you probably were the one that introduced me to the idea of emotional labor within this context. Because one thing that statisticians are definitely not trained to do is you go into a meeting about statistical methods with public partners, and you might come out knowing their life experiences, but you're not used to that. So that might make you uncomfortable. And that's something that needs to be talked about, because there is emotional labor in sort of having these discussions, being there for the other, aspects that we're not necessarily used to in statistics or even in quantitative research. So Lynn, what are your thoughts on that?
Yeah, I mean, I think when I'm often asked by researchers how to do patient public involvement, and that's important, but also the being is important. So what values you need to inhabit as a person in order to do it. And it does come with huge emotional labour. And it's not, and I think that's recognised for public partners, but I don't think it's recognised for researchers and PPI leads and whatever in the same way. And this is like, there's a different dynamic, I think, here from maybe relationships that you're used to having with fellow researchers. And if I go back to Sarah Knowles' great paper, it's about embracing the productive tensions. Actually, we don't always have to agree, and that's okay. It's building relationships to get you through that. You know, which B and I have done over a period of time. And I think, you know, a lot of this requires the so-called soft skills as opposed to hard skills. And I think this comes back to what's valued in research. You know, is it things like impact factor, the journals that you publish in, your grant income, or is it that you can actually build relationships with people? And I think sometimes this is an issue of the value assigned to doing patient public involvement by the academic system and who's expected to do it, because it's often highly gendered. It's left to or looked to be that it's like young female researchers that they're expected to do it because they can do relationships. And there's a great, I'll need to pop in the chat as well, a great qualitative study by Stan Papoulis and Luca Brady was published this year, looking at the work of PPIE leads and how actually PPIE is meant to bring about transformation in a system and culture that actually is not really interested in transforming, because we can come up with toolkits and frameworks and whatever, but the bottom line is that when it comes to patient public involvement, culture often eats strategy for breakfast. And actually, what is the culture in which you exist, and whether that allows the relationship that you have with public partners to thrive.
Yeah. It makes me think about that some of these productive tensions, this is such a great term, as you said, because it speaks to the fact that we might disagree, but what we find on the other side is much better than what it was before.
Sure.
And there's also this honesty about the relationships, which is related to, you've mentioned something earlier about the systems and I think you said life world, and we had this discussion before, because Lynn has come to the meetings and said, are we trying to sort of start from scratch, or are we within the current system, within the current culture of thinking, trying to give some input, change some things, but it's not breaking down the whole thing? And we've had these conversations, and we've talked about the fact that it would be great to do something like that, but at the moment, for example, Pinpoint is very much within a clinical trial setting, and very much trying to address what exists. So I'm trying to showcase that we can have these discussions and we can be frank with each other, and not feel frustrated about it, actually feel quite enriching after, because I feel like we are moving, you know, step by step, maybe small steps, but still step by step, we're moving in the direction of opening up the conversations. So I'm going to move us to reflexivity, which is something that I've never heard of before I took a 1-week course in qualitative analysis. So through my whole training of statistics, never heard of it. So I brought the definition, Lynn, because I thought it might be helpful. And it's quite a simple definition from the perspective that maybe we should all be doing this all the time in our lives. But it's the idea of examining one's own assumptions and beliefs and judgment systems, and thinking carefully and critically about how these influence the research process in particular. And so I like this idea of the key question about it, and Lynn then pitch in if you have other key questions, but what is the research process and how am I influencing it? And as I was reading about it, I thought this is such a difficult thing for quantitative researchers to do, because we're never taught that we as an individual are influencing the system, I think. And I'm curious to see if, other people that are in the call would agree or disagree with me. But so it puts us in a different new position, uncomfortable, yes. But do we learn something from it? Definitely, because we are influencing it, and we do have power over certain decisions, from the junior statistician that's deciding how we handle missing data, to the senior statistician that makes calls on, what data is getting collected and how is it going to get collected, which are obviously, decisions with a lot of implications. So thinking about why are we choosing what we're choosing, why have we identified this group of people as the group of people that needs to be in our research? All of these different things are important to consider. And I don't think there's a tradition to do that in statistics. So Lynn, do you want to say a bit more about?
I think the only thing I would add is that being reflexive is challenging, and I found that once I switched it on, it was really difficult to switch off. And I think it's hard for a reason, but I do think it brings a lot, and it could do to the statistical parts of research if we allowed it to
happen. So basically, this was influenced by conversations we had in the past. We didn't pinpoint when we were getting to the sample size discussion. That's one of the pieces of information we're going to try and collect. And as we wrote it, we all acknowledged that we don't know how it will work out, because we're asking members of the sample size teams, all these statisticians, chief investigators, public partners, we're all asking them to go away and reflect. So before and after, reflect on what are they bringing to that discussion and how do they feel afterwards. But it does also bring this idea of we need to acknowledge not just what goes right, but what goes wrong. Right, Lynn? Like we've also had this discussion about the idea of PPI in statistics, in data research, and in any setting will not always go right. And we need to, again, feel like we have a trusting relationship so we can bring this up and see how can we move forward. So it's not about being positive all the time, it's about questioning things. And I think reflexivity could really help in that, in how do you become a better leader or a better PPI lead within your own research project. So it's not just about, I suppose, the statistical research, it's also about if a statistician is interested in doing patient and public involvement. One potential way to do it and to improve could be to that. And I must confess, Lynn, I don't do it regularly. So I'm still not, I'm convinced by the idea. I still don't do it regularly. I reflect after, but for example, before I come into it, not necessarily. It's something that's not still second nature to me.
Yeah, it's time, isn't it? Time and resource. A lot of these are and we recognise a lot of what we're talking about is time and resource dependent.
And culture, I suppose, as you said earlier.
Yeah.
Yeah. So I had this slide on bringing reflexivity to statistics and bringing it together with that paper, the original paper I showed in the slides. I'll post links in the chat, like Lynn very helpfully has done with hers. And so it's about objectivity and subjectivity in statistics. So these are not my ideas. These are Andrew Gelman's and his collaborator ideas. But these are about being conscious about how statistical choices reflect or ignore alternative viewpoints. So if you go back to the pinpoint example, it was this idea of, we ask clinicians all the time, do you think this looks like a reasonable difference between groups? We have done it with patient and public partners. And we could get into a discussion here about why not, because there will be reasons, cultural reasons, but also, methodological reasons why people might think it makes more sense here or there. But it's the fact that we don't even debate them. We just assume that one viewpoint is enough, and it is the clinician viewpoint. And I think that needs to stop, to be honest. I think we need to evolve past that. So recognize that modeling and inference choices depend on specific goals, domains, and data collection processes. Whatever we're going to reach is dependent on how did we ask it, when did we ask it, to who, and we need to be very conscious of that. Acknowledge that different stakeholders may view the problem differently, examine how sensitive results are to alternative decisions. A lot of us probably already do that through sensitivity analysis and being transparent of statistical decisions, which in the clinical trials world, I would say is a norm. So we are transparent about our decisions. What I think we should do better is opening up those decisions and acknowledging that they are subjective, they're not objective. So I just wanted to leave this final reference for those that are interested in this discussion. A group of authors published on reflexivity and quantitative research. They're coming from a psychological and social sciences quantitative research background. I must say I didn't always agree. Again, there were parts of it where I at least felt tensions. But as I said over and over again, I think that's what makes us better researchers, is that we are willing to learn and be curious about other points of views, and then of course you'll make up your mind about something, and that's part of the process. So that's it. Lynn, do you want to add anything before we finish?
Just I suppose I go back to the point about it's making things better, actually. and I think, you know, working together in this way, being reflexive, being aware of the emotional labour and whatever, I think is the key, yeah, to a lot of it, although challenging.
Hopefully the idea is that making statistical research, data science research more relevant to those that we want to benefit. And it's how do we get there in an honest and transparent way.
Thank you so much, both. I really liked the way that you presented the bouncing between the two of you. I thought it worked really well. It was very like dynamic, and yeah, so that was cool. We do have some questions if that's all right. So there's a couple in the chat, so I'll start with these. And you can decide if one of you would prefer to answer over the other. Or so the first question, and I guess this is referring to the fact that, you know, if you work on the assumption of the researcher, lived experience researcher, sort of, you know, just communicating with each other, working with each other. So the question, as a clinician, a pharmacist, I can identify with some of the points mentioned. For example, primary outcome is not meaningful to clinicians, or important adverse effects not being studied. So yeah, the sort of the role of clinicians within that.
Yeah, so that's a good question. And actually, the paper that I mentioned by Sean Treweek looked at what public partners thought of the primary outcome and also clinicians. And you know, I think it's something that's not done enough. And I suppose a lot of the points we are making I don't think they're unique to involving actually public partners in research. I think there are other stakeholders, although that's not a term that I particularly like, and that often it's managing the tensions in the room with regards to power. You know, and how do you make the ultimate decision when we're coming at this from different contexts and whatever, we're not going to agree. And I'm not sure that we surface that enough, and that goes back to the productive tensions. Actually, how do we and what are the relative power? What power do the different groups hold in the process?
Yeah, so I completely agree. In previous projects, Lynn and I have worked with clinicians. So for example, to determine priorities in when to involve patients in numerical aspects of trials. And I think one of the key things I took away at the time from it was that we need to be very aware of tailoring preparation, and availability to different needs, independent of whether clinicians, patients, we just need to be ready for that. Because as you get into a room with a different group of people, as Lynn's saying, that will disagree, a lot of it is in the preparation. And how did you prepare those people to be there so they don't feel like there's a massive power imbalance? And this is also true with statisticians, right? Because we will come in and we might start throwing some jargon, and statistical jargon, let's be honest, sounds quite fancy. So, you know what I mean? It is that preparation, I think, is crucial in order to try to maximize the chances of a productive discussion.
So real clarity, beforehand, before you even start that meeting.
And the purpose, just being clear about the purpose.
Yeah. It sort of sounds so simple when we say it like that, but it doesn't always happen, does it? I suppose. Okay, there's another question here, and that is, are there any reflections on the expectations of statistics from the PPI representatives? I'm not 100% sure the interpreter, but Daphne, you're welcome to join the chat if you want to clarify. Hello. Oh, is Daphne still there?
Hi.
Hello.
Hi. So I just wondered if there are any thoughts about how feel about statistics. I mean, statistics is regularly under fire. Statistics is being, all the abuses of the data is blamed to the statisticians or statistics, or actually it's about the data. And I just wonder, are there any myths or any understanding from the PPI, from patients about what statistics is about and how they understand it, and what they think it is? And do they think, for example, that data are not facts, or how this data came to be, have a story, and it's usually like history, or it's not definite things are subject to interpretation. So it's not the application of statistics that has interpretation. The data that statistics is based on is subject to interpretation. They have their own history of how they were collected, why, for what purpose, or they might have brought from different sources. So, I'm just coming from statistician where I'm regularly attacked about what this data means and what do I do with them. And we have principles, ways of dealing with them, but we don't make the data.
Yeah, I think that's a really good question. So if I can be really reflexive, I think it taught me, I had to, so when I co-produced a piece of qualitative research into people's shielding experiences, it was like, and I helped with the application and actually did the research. And that was, I think as a public partner, you are protected from a lot of the stuff that goes on. And I'm co-investigator on a fellowship who are running a clinical trial at the moment. And that, I think we get siloed, don't we? And we need to, so as well as researchers coming into the life world, public partners need to come into the system world as well, and understanding. And I think it's that shared experience and understanding which goes back to the relationships that you build, which negates this working in silos and being the PPI or the researcher. And I think it's a really good point about the data sets, because if COVID showed us anything, it showed us actually a lot of the data we have, certainly in terms of ethnicity and other things, actually just isn't fit for purpose. And that's something that we need to do something about collectively, working together. But I think the system and the culture likes to silo us, and that's where a lot of these
it's
It's actually a right of all of us as taxpayers of having a say of where public money goes.
Yeah, and I think just highlighting what the issues are from these different perspectives, and then it's, well, actually, who's got the power to do something about it? But I am not as, I mean, someone said to me the other week, God, Lynn, you can be brutal, and I try not to be brutal anymore when I have a better understanding of what it's like, or what are the issues for statisticians. And a lot of that has come from the relationship that I've built with Bea and other people. Yeah.
Yeah, because it speaks to the fact, Daphne, I think your question also speaks to the fact that there are forever power imbalances across. So a public partner might think that the statistician has the power to do something, and the statistician in that room might feel like they have no power because it's the senior statistician, and the senior statistician thinks the chief investigator, and so on. So it is important to acknowledge that sometimes we want to do better, but we feel like we can't because we're constrained within a certain culture or within a specific data set, right? So and I think that's valid, and it's important to be aware of, and maybe to state the limitations of what we have from the get-go to public partners, to make sure that there are no expectations about changing things that can't be changed at that point.
Thank you all. It's great. We have another question in the chat from Keelan. And so Keelan is asking, he's really interested in the co-production work you mentioned on developing and adapting the tools used in the pinpoint study. Could you share some examples of how you practically run these sessions? For instance, did you present early prototypes of the tools and gather feedback from contributors?
So we started with a scoping review. We then took specific examples to public partners. It was all informed. We had way too many things happening. And then Lynn, Derek, and Irene said, that's not going to work. And so we learned with them and then took it to the public partners. And it has worked really well. What I could do is, if you could send me an email, I'll just reply to you with my email. I can actually give you specific examples. I think that's what the question's asking for. But that was the process. It was through a review. We gathered examples. We've selected them to showcase them to public partners. But in the meantime, we had the strategic meeting with our advisory group to decide the best ways to take it forward. And there's been multiple meetings. So we didn't just have one single meeting to decide on tools. It's been a 4-workshop process, and there's still some question marks at the end. So it takes time, which is normal. I think that's part of the expectation, is that it takes time, and that's why sometimes it can be harder to do.
Yeah, and I think as well, it's just really quickly. So I helped co-produce a rapid critical review of the evidence for the value of co-production project, which was managed by the Co-Production Collective based at UCL. And actually, when you look at, Bea's talking about doing a review, and I have found when I've helped co-produce systematic reviews or whatever, if you look about who's producing the evidence in these, public partners are very often not included. And I think that's something that I always do when I'm helping with systematic reviews, is actually looking at who is it that's developing these tools. And are they developed with people, or are they developed for people? And I think that was something that we brought out about the review is well. Well, it's like this. It's like the mobile thing. Again, what you think is good might not be actually what someone's experience is.
Thanks, Lynn. Raquel, did you want to?
Yeah, just have a follow-up question following the Keelan's comment. I would like to put the emphasis on the tools to gather feedback from the contributors. I think it's so important to being able to assess the impact of our PPI activities. And sometimes we are a little bit lost on this part of the session, right? It's like, I would love to have a clear idea on how my group was impacted by the session that we have run. And I would like to know, we have to tailor the assessment to every group, or there is any existing resource or tool that we could adapt and use for this? maybe that it doesn't exist. I just wanted to know exactly how we should do that, because we are struggling with this at the moment.
So there's a Pirate tool, which was developed in Wales, but actually I think that Christina Staley has written lots of really good stuff on impact and evaluation, and where I don't get involved to have my impact evaluated. And actually, are we evaluating the difference that I made or the difference I could have made if things had been set up correctly? And actually, why are we not evaluating the impact across everyone involved, not just public partners? So while I understand the need to understand the impact, I think that we really need to think very carefully. And it's another thing that we're bringing, this is a research world thing, this is a system world thing that we want to put in, and actually does it fit with the values and principles of involvement? Yeah. So just a wee pushback there.
Yeah. So basically, in terms of the pinpoint, we are going to that reflexivity that everyone's supposed to do. The idea is to sort of try to assess the impact on everyone, because you can walk out of that discussion with a statistician that's super frustrated, let's say, or a chief investigator that's annoyed, and we want to find out all of those different pieces. But we also use traditional ways, and I totally get Lynn's point of that pushback of, I would like for the research team to also think about the impact on themselves and how did they change their views. So I think that's a really good point that I should do better at too, Lynn. And we've been collecting data, Raquel. We basically tailored it. So we didn't use a pre-specified tool in the workshops, not as part of the advisory group, actually, Lynn. We haven't done that yet anyway, but as part of the workshops, we've collected data from public partners about how we were doing, and tailored it. I could share it though, if of interest.
Thank you so much. Thank you.
Right, well, the clock has just ticked over to 4 o'clock, so I guess we've run out of time. But that was really a great presentation and discussion. Thank you again, both Lynn and Beatriz, for joining us. We will share a recording of the event. And that will be on the BRC website. So you're welcome to share that with others who couldn't make it today. If they're interested in the topic, please do. And just to say, the seminar will switch to prediction modeling focus for the next one. That's on the 26th of November. So do join us again. And thank you, everyone, to our great speakers and also to the audience for the great questions.
Thank you. Thank you for having us.
Thank you.
Pleasure.
Bye.
Thank you.
Pleasure.
Bye.
All the best.
Bye.